Muy buenos días, ahora sí, vamos a comenzar. Estamos en vivo desde la ciudad de Buenos Aires y a partir de este momento comenzamos con la videoconferencia del doctor Tommaso Bigniardi con la siguiente temática: endometriosis of the ovaries, endometriosis of the uterus, endometriosis of the bladder and urinary tract, endometriosis of the posterior compartment, rectovaginal septum, uterosacral ligaments, and extrapelvic endometriosis. Mi nombre es Martín y estaré a cargo de la moderación de este encuentro. Les doy la bienvenida en nombre del Simposio Internacional de Imágenes en la Mujer, ITCBA, Centro de Diagnóstico. Les doy la bienvenida nuevamente y les agradezco su presencia. Les quiero recordar que durante todo el encuentro van a poder hacer preguntas, van a poder hacer comentarios a través de la opción del chat que tienen. Nos pueden ir enviando las preguntas que nosotros le haremos al doctor en el momento que él considere pertinente. Vamos a recibir en segundos entonces al doctor Tommaso Bigniardi. Tommaso, good afternoon for you. So now everybody's online, so we want to thank you for being here and we're ready to listen to you. So when you are ready, you can start.
Okay, thank you very much. I organized this workshop on endometriosis for the purpose to give you some indication on how to investigate women with endometriosis with the use of ultrasound. And you can see on this slide on the left corner the picture of the hospital I'm working. Is the Ospedale Niguarda. Is the largest hospital in Milano. I run a clinic in this hospital where I see women with endometriosis, so I used to scan these women and bring them to the operating theater if necessary. And we have a multidisciplinary approach in the sense that we cooperate with surgeons, radiologists, and other specialties. I would start with the posterior compartment because I think is the most actual and most interesting aspect of today. What we define as a posterior compartment, all the anatomical structures you can see on the right side of the this dotted red line. So the rectovaginal septum with the posterior vaginal wall, the retrocervical area with the insertion of the uterosacral ligaments, and the rectosigmoid. So the last bit of the bowel. So we will focus on this presentation on the investigation of this part of the pelvis, which is usually not much seen by the common gynecologist, but is very important if you want to scan women with endometriosis. The posterior compartment is the most common place which is interested by deep infiltrating endometriosis. We define as deep endometriosis a nodular disease in the pouch of Douglas or the invasion into the muscularis of the bowel. So the common forms in which this disease manifests itself is a bulky disease, whether in the pouch of Douglas or in the bowel wall. We define as bowel endometriosis if the endometrial glands and the stroma of the endometrium reaches at least the subserosal fat or the neural plexus of the bowel wall. This is a very famous study on the anatomical distribution of the deep endometriosis lesions, which was made by Chaperon, so in France, and we can see that the most common sites of this bulky nodular disease are the uterosacral ligaments and the bowel. and is followed by the vaginal wall, the bladder, and the ureter. In our place, we see a lot of referral from other hospitals with women with endometriosis, and in center like us, so in tertiary referral center for this pathology, the prevalence of bowel endometriosis has been described up to 30% of women we see every day in our endometriosis clinic. In older studies, it was described around 10–15%, but in our experience and in other case series, for example, from Abrao in Brazil, from Redwine in the United States, actually the prevalence is much higher and probably is growing because our ability to see this pathology on ultrasound has improved. From the histological point of view, bowel endometriosis we define as infiltration of endometrial glands stroma into the bowel wall, which may become thickened. There's an hyperplasia of the smooth muscle cells, so the bowel wall become more rigid and the lumen of the bowel may narrow, as you can see from this specimen, which was from a segmental bowel resection. You can see that the bowel is completely distorted, the bowel wall, and thickened, and the lumen inside the bowel is very thin. From the point of view of the degree of infiltration, endometriosis may infiltrate only the superficial layer of the bowel, so only the serosal layer. Most commonly, it infiltrates the muscularis of the organ. So this is the most common situation, infiltration of the muscularis of the bowel wall, which is partial thickness in most cases. In most advanced cases, the infiltration may interest all the bowel wall in its full thickness, so it can go through the muscularis into the mucosa of the bowel. But this is less common. Even lesser common is the isolated infiltration of the mucosal of the bowel, which may have an origin from a lymphatic spread or hematogenous spread. But this is very, very rare. From the point of view of the distribution of the sides of the bowel wall, which are most commonly involved, in most cases these nodules are located anteriorly, so to the opposite side from the mesenteric of the organ. We can have lateral lesion and very rarely also posterior lesion, so lesions that are affecting also the mesenteric of the organ. But usually these lesions are part of a circumferential lesion, of a stenotic lesion. Which are the tracts of the bowel which are most commonly involved by endometriosis? In this study from Chaperon, the most common site is the rectosigmoid junction and the rectum, which are the almost more than 2/3 of the cases. Less frequent is the involvement of the right side of the bowel, so the cecum of the ileocecal junction and the appendix. You can see in these pictures from laparoscopy on the right upper corner small implants on the serosal surface of the ileum, of the small bowel. The involvement of the small bowel is less frequent than the rectosigmoid, but is the most difficult to diagnose preoperatively. Next to this picture, on the left, there's a picture of an obliteration of the pouch of Douglas, with the rectum which is retracted and completely adherent to the posterior retrocervical region. In the lower picture, you can see an implant on the rectosigmoid, which is causing a retraction and a kinking of the rectosigmoid. In this paper that I did when I was in Australia, we tried to go and see what an obliteration of the pouch of Douglas, what implication may have an obliteration of the pouch of Douglas for these women when we speak about surgery. And we basically see that if the pouch of Douglas is obliterated, these women have a high risk of bowel surgery, whether it could be only a bowel shaving or more invasive procedure like resection of part of the intestinal wall, of a segment of the intestinal wall. These women with an obliteration of the pouch of Douglas had almost 60% risk of this kind of procedure. So it is very important in order to give a proper counseling of these women before surgery to diagnose this disease before taking these women to the operating theater. The operating room should not be the place where this disease is diagnosed for the first time. Transvaginal ultrasound in the last years have demonstrated to be very accurate for the diagnosis of this disease before surgery, and is very reproducible, very cheap, and so it could be the first imaging technique to diagnose deep endometriosis. This is a meta-analysis that shows the diagnostic accuracy of transvaginal ultrasound to diagnose bowel endometriosis, and we see from pooled data on sensitivity and specificity that is the accuracy is very high, above 90%. So my purpose is to give you some indication how to perform the study of the pelvis when you have a suspicion of bowel endometriosis. Always my suggestion is to start with the bimanual examination. So the vaginal examination is of paramount importance before doing ultrasound, because with your fingers sometimes you can feel nodules, very small nodules that it may be difficult to see first thing with ultrasound. So first thing is to start with bimanual examination. Then you start your ultrasound and you do like a recognition scan in order to look to look briefly at the position of the uterus, at the position of the ovaries, to look at the morphology of the uterus and the ovaries, and trying to look for simple signs that can raise your suspicion of deep endometriosis. And this should be first, and I didn't put it in this slide, but first, if you have, for example, an endometrioma. If you have an endometrioma, you should look carefully for the presence of involvement of the posterior compartment, because in cases of bilateral endometriomas, studies have shown that there's a 30% risk of bowel endometriosis. So look at the position of the uterus, at the morphology of the ovaries, presence of endometriomas. Look at the presence of tenderness points, because always the tip of the probe is like your examination finger. When you push with the probe and you can feel that there are some points that are more tender than the other, that should erase your suspicion of endometriosis. Then another quite simple thing that you can look for is the sliding sign and the ear sign, and we'll have a look at those. After your suspicion have increased for bowel endometriosis, you should go and look carefully to examine the bowel, the retrocervical region and the region of the uterosacral ligaments. So we can start video 1, please. I cannot see any video. Hello? Can you hear me?
Tommaso, we are watching the video number
See?
1 right now. I don't know if you are seeing it also.
No, I cannot see the video 1. Well, I remember the video is a video showing the sliding sign. Basically, you push with the tip of the probe against the cervix in the posterior fornix, and you see the sliding of the rectum anteriorly, of the anterior rectum, towards the posterior uterine wall. If it slides smoothly, if you can see that movement, you can say that the sliding sign is positive. I cannot still see the video.
Tommaso, I don't know why, but everybody here is watching the video, so if you remember
the video,
them,
okay,
you can
okay.
speak about them.
I remember
or you
them.
can, play in your
yeah.
computer, but don't worry that
Okay.
everybody's watching the videos here.
Okay, that's fine. Video 2 is another video about a sliding sign, but in another location. Because after you've checked the sliding sign behind the cervix, you should check it at the level of the uterine fundus. So you keep the probe, you keep pushing with the probe against the posterior fornix, and then with your left hand, non-dominant hand, you press in this suprapubic area, you press at the level of the fundus, and you see if the bowel wall slides freely against the fundus. So if the sliding sign is positive in each of these two sites, you can tell with a high degree of accuracy that the pouch of Douglas is not obliterated. The sliding sign has been already validated as a sign with a high sensitivity and specificity, and with a very acceptable inter and intra-server agreement by the Australian group. So you should start to incorporate this sign in each evaluation, in each transvaginal evaluation. So we can see that the sliding sign is positive. If the sliding sign is positive, there's no pouch of Douglas obliteration. If in any of these locations the sliding sign is negative, there's a good correlation with the pouch of Douglas obliteration. Another simple sign that should arise your suspicion for an involvement of the posterior compartment by endometriosis is the ear sign. So basically, the shape of the uterus starts to resemble that of a ear. So it's not a simple retroversion of the uterus, it's more likely a retroflexion, a fixed retroflexion, because the uterus is not mobile and is caused by the process of the endometriotic plaque, which can cause a retraction of the uterine fundus towards the pouch of Douglas. And you can play video 3 and 4 and you can see what I just explained to you, what an ear sign is.
Okay, Tommaso, we will be playing now video 3, video 4.
Okay.
So everybody here will see those videos, so you can continue.
Okay, just tell me when you're done with the videos so we can go on.
Okay, Tommaso, we have just seen video 3 and video 4.
Okay, thank you. So now that you had your recognition scan, that you look at the shape of the uterus, you look at the ovaries, the presence of endometriomas, you've checked for the sliding sign and the presence of the ear sign, of the tenderness points, you should start to go on with the examination of the bowel. And my suggestion is for people who start to, for the first time, to look at the posterior compartment, to start examining the lower rectum. So the anal canal, because it's the part of the rectum which is less interested, so it's more conservated and easily to see for the first time with ultrasound. After that, by inserting the probe deeper, you should follow the course of the rectovaginal septum. You should follow then the course of the rectum cranially into the rectosigmoid and sigmoid colon, easily by tilting your probe towards the left side. And notice the presence of nodules and the course of the rectosigmoid. How to examine the lower part of the rectum? Well, you can see in this picture, this is a mid-sagittal section. You see that the probe has been retracted towards the level of the introitus, of the vaginal introitus. So at the entrance of the vagina. So when you've done with your recognition scan, you retract the probe at the level of the introitus and you tilt the probe upwards with an angle of about 60%. Okay? In this way you can depict a mid-sagittal section of the rectum. You can see the two pictures below. you can recognize the first curve of the rectum, which is the closest to the anal verge and is about 3 centimeters to the anal verge, and then the second curve of the rectum, which is about 8 centimeters from the anal verge. The first curve has a convexity which is anterior, while the second curve has a posterior convexity. What you see depicted with a star is the reflection of the peritoneum at the level of the pouch of Douglas, which is about 7 centimeters from the anal verge, so about 1-2 centimeters below the second curve of the rectum. If you tilt your probe on a transverse section at this level, you can have a coronal picture of the bowel wall layers of the rectum. And you can see how the bowel appears on ultrasound. With high resolution, with the resolution of the modern probes, we are able even to recognize all the layers of the bowel with a very high resolution. From outer to the inner, you can see an hypoechoic layer, which is the muscularis layer. And you can see in this picture that you even see that is made up of 2 separate layers, a longitudinal external and a transverse internal. If we go towards the lumen of the bowel, there's another hyperechoic layer, which is the submucosal layer. If we go more towards the lumen, the mucosal layer. In most cases, you are not able to recognize the mucosa from the submucosa because the lumen is collapsed. But in this case, there was some fluid inside the rectum, so we were able to see even the mucosal layer separated from the submucosal layer. But in most cases, you will only see a single hyperechoic layer, which is made up of the submucosa and mucosal layer. It's very important to understand this constitution in layers because, as I've already said, the layer which is most commonly involved by endometriosis nodule is the muscularis layer. This is a volume acquisition of the last tract of the rectum. You can see on this multiplanar display on the upper left corner a coronal section of the rectum with a clear hypoechoic layer, which is made up by the muscularis layer, and the inner mucosal layer, which is hyperechoic, and you can see the lumen of the rectum. On the right side, you have a sagittal section with the first curve of the rectum and the anal sphincter. So my suggestion was to start from the lower rectum because it's the most easily assessed and you can learn this stratification of the bowel from this point and it's quite easily to understand. When you're done with this examination of the lower rectum, you insert the probe deeper and you look at the rectovaginal septum. So you look posteriorly at the posterior vaginal wall. In this 3D acquisition, you can see that line, that hyperechoic line that separates the anterior rectal wall that you can see on your left side from the posterior vaginal wall and posterior cervix that you can see on your right side. In this case, there was some fluid in the pouch of Douglas that you can see inferiorly. You can see that the rectovaginal septum is depicted as an hyperechoic line that continues to the pouch of Douglas, to that connective tissue which is at the base of the pouch of Douglas. And in this case is well depicted, and there is no interruption of this rectovaginal septum, and you can see it quite clearly that it's a bright line. So now, if you could play the rectovaginal nodule video, this is video 5.
Okay, now we are watching video 5, Tommaso.
Yes, this is an image, a video of a rectovaginal nodule. So it is a nodule that infiltrates the rectovaginal septum. This nodule appears as an hypoechoic nodule that interrupt the hyperechoic layer of the rectovaginal septum. Let me see if I can. Hello?
Yes, Tommaso, we are
watching
you and we'll listen to you, okay.
Okay. So this was a picture of a nodule that was infiltrating both the rectovaginal septum and the vaginal wall, the posterior fornix. You can see that the nodule is infiltrating the posterior
yes, Tommaso,
fornix.
We are watching you and we'll listen to you, okay.
If we go more cranially, so if we follow then the course of the rectum into the sigmoid, we start to see rectosigmoid nodules. So these kind of nodules are higher than the rectovaginal nodule. Once everybody was putting all this nodule in the same definition of a rectovaginal endometriosis. Now we are able to see very clearly which is the level of this nodule. So we should start naming this nodule with the right name, which is given by the anatomical structure they infiltrate. The first nodule was rectovaginal, so rectovaginal septum and vaginal wall. This nodule, rectosigmoid nodule, because it's higher. If you play video 6, this is a video of a rectosigmoid nodule. So
okay, we're now watching video 6.
You can see that this nodule appears as a hypoechoic nodule, like a thickening of the muscularis layer of the rectosigmoid colon. And you can see that it's at the level of the posterior wall of the uterus. So it's higher than the rectovaginal septum. And we should call it rectosigmoid nodule. As I said before, this nodule, in most cases, are infiltrating the anterior wall of the bowel, so the antimesenteric side. And this helps us to to see them because they are very close to the tip of the probe. Have you done with the video?
Yes, we're done with
Okay.
video 6. Now we're watching video 7.
Video 7 is another rectosigmoid nodule which is bigger, so a more advanced stage. This nodule is quite
Yes,
big.
we're done with
As I
video
remember
6.
well, it was about
Now
3
we're watching
centimeters.
video 7.
And in a mid-sagittal section, it can appear as the head of a mushroom. You can see that has a profile towards the lumen of the bowel, which is like the digits, like fingers. And this is a sign that somebody called the Indian cap sign, because it resembled the cap of an Indian with the feathers. And it is a sign that there's an infiltration and retraction of the submucosal layer of the bowel. And you can see it especially for bigger nodules. Have you done with the video?
We are done with the video.
Okay. This is a picture of a rectosigmoid nodule that has been removed surgically with a rectal resection, which was made laparoscopically. And you can see
We are done
on the
with
right
the video.
side the specimen, the thickening and the retraction of the bowel wall with a reduction of the lumen of the bowel. On the left side you can see the this nodule, which is hypoechoic and has an appearance which is quite big, is more than 3 centimeters, and it's causing a retraction of all the structures that are in the posterior compartment. The fundus of the uterus is fixed and retracted towards this process, this disease. Now these are 2 videos that they are not from the same patients, but I saw the patients on the left one day, and like 2 days after I saw another patient, and I remembered about the first patient, and it looked like it was the evolution of the first patient, the second patient that I saw, because their ultrasound is very similar, and it could be like like the first patient we scanned it, I would say 2 years ago, and then the late stage of the disease, because the early stage you can see in video 8, which is the video of the an early lesion. You can see that the sigmoid is very adherent to the uterus fundus, to the fundus of the uterus. If you push with the probe, you cannot separate the sigmoid colon, which is attached to the uterus. At this level, the bowel wall is thickened, and you can see a small nodule. So this is how probably they first appears, this nodule. On video 9, there's a similar video, but the nodule is bigger. The nodule is bigger, and there's a much more retraction and deviation of the normal, of the normal course of the sigmoid colon, and also a certain degree of stenosis.
Okay, Tommaso, we have just seen video 8 and then video 9 when you
Okay.
were speaking about them.
Thank you. With ultrasound, we are able, because of the fact that these probes now have a very high resolution and the tip of the probe is very close
Tommaso,
to the
we
bowel
have just
wall,
seen video 8 and
we
then
have
video
a
9
special
when you were speaking about
point
them.
of view if we compare to gastroenterologists that are using transabdominal probe. We are able to look carefully at the layer of the bowel and see what is the degree of infiltration of the thickness of the bowel wall. As I showed you in the previous videos, very big nodules, it's very likely that they are infiltrating the submucosal layer. So this kind of study, basically we should do it only for very small nodules, that they may have another kind of surgical approach beside a full segmental resection. Very small nodules that are not infiltrating the submucosal layer, we can approach this nodule with, for example, a discoid resection. So only a disc of this bowel wall can be removed. But we have to be sure that they are not infiltrating the submucosal layer. And as you can see, the profile of this nodule on the left, the profile towards the lumen is very smooth. So you cannot see any interruption of the submucosal layer, which is the hyperechoic layer towards the lumen. So it's very likely that this nodule is not infiltrating the submucosal layer. But if you see an image of minus at the level of the hyperechoic layer, which is the submucosa, there's a possibility that this nodule is infiltrating the submucosal layer, and so this kind of surgery is not possible. Like you see on the right, on the picture on the right. Another, as I already explained to you, another sign that correlates with an infiltration of the submucosal is that appearance of digit of fingers that Guerriero, that Stefano called the Indian cap sign. Another thing that you should start looking is the normal course of the rectosigmoid. What you easily see is the structure that you see much easily is the muscularis layer, because it's hypoechoic. And normally these two layers of the anterior and posterior wall, their course is almost parallel. And they can make some curves, but they're usually parallels, as you can see in video 10. When you have bowel endometriosis, advanced bowel endometriosis, there's a retraction of the rectosigmoid. So these layers, these hypoechoic layers, they seem to converge into the lesion, because that lesion is retracting and fixing the course of the rectosigmoid, as you can see in video 11.
Now we are watching video 11.
Okay, thank you. So that's another sign that you should start looking when you examine the posterior compartment, the course of the rectosigmoid.
Now we are watching video 11.
This is a
Tommaso.
video of a vaginal nodule. Sometimes, but quite rarely, these nodules are infiltrating only the vaginal wall, so they are isolated to the vagina. And you can see this small nodule that is infiltrating the posterior vaginal fornix in this video. But you can see clearly that the pouch of Douglas is not obliterated. There's some fluid in the pouch of Douglas. So sometimes you can have a normal pouch of Douglas but a vaginal nodule. And this woman, in these women, it's quite easily to miss this nodule. So that's why I focus the point on the fact that these women needs to have a vaginal examination before scanning, because you could feel with the vaginal examination this nodule that was quite tender, painful. Uterosacral ligaments are quite difficult to...
Okay, we just watched video 12 and now we are watching video 13.
Okay. It is now the time to have a look at the retrocervical region and the uterosacral ligaments, which we've seen from the previous reports that they are very commonly involved by deep endometriosis.
12, and now we are
So
watching
if you
video
start
13.
from a mid-sagittal section at the level of the posterior fornix and the posterior cervix, you should tilt your probe laterally from to the left and to the right, and you reach this region of the uterosacral ligaments. Usually, if they are normal, it's not easy to see them. But if there are some nodule, you are able to see them. And this nodule usually appears as, again, hypoechoic, and they usually have a like irregular margins, like infiltrating margins. Most of the times they are painful when you push with the probe. This is another picture of a uterosacral nodules. You can see the hypoechoic nodule. We are in a parasagittal section at the level of the posterior fornix. There's another video of a uterosacral nodule. This was a smaller nodule, if I remember well. And if you push with the probe, with the tip of the probe, you see that this nodule, they move together with the posterior fornix, so they don't move with the bowel wall. So they are nodule of the uterosacral ligaments.
Okay, we have just watched video 14.
This is another picture of a uterosacral nodule. This is a smaller one. You can see it. You can see the posterior fornix
just
on top,
video 14.
and just below it a small hypoechoic nodule with irregular margins. Another concept that I would like to stress is that we've said that the most commonly affected sites are are on the left side, but in most cases a rectal lesion is associated with the second intestinal lesion. So in more than half the cases, if you have a lesion in the rectum, there's a second intestinal lesion somewhere else. Moreover, rectosigmoid lesions are associated with ileocecal lesion in 28% of cases. So this contradicts what we've said at the beginning, but it is a more recent acquisition, this one. So probably lesions on the right side are more frequent than we thought. And this is quite important because for the purpose of surgery, because we need to be clear to this patient that if we do a resection, a simple rectal resection, they may have a recurrence somewhere else. This is a video of a multiple lesion. So you can see a nodule just next to another one. And this situation is more common than we thought. And it's very important because if you are a surgeon and you are dissecting the bowel to perform a bowel resection, and you did not study well this patient before bringing her to the operating theater, you may perform a resection of the more cranial nodule but leave the caudal nodule behind, and so the patient may have a resection, may have a recurrence, but this was not a recurrence. This is because you left the other nodule behind. So it's very important before bringing these women to theater to do a proper mapping of the lesion. And how can we do it? I mean, is it enough to do a transvaginal ultrasound? Should we add some other investigation technique, like double contrast barium enema, like an endorectal ultrasonography, a CT scan, an MRI? Well, I cannot give you an answer at this stage, but because most of these techniques have been used and studied in the past, but we don't have a clear answer if some of them is better than the other. Transrectal ultrasound has the advantage to be very accurate on the layer of the bowel. So if we have a very small nodule in the bowel and we need to know if it infiltrates the submucosal layer, you might request a transrectal ultrasound to be more accurate. But today transvaginal ultrasound has been demonstrated as accurate as this one. And this kind of ultrasound has the disadvantage of being of not going deeper in because the resolution must be higher to the structure that are very close to the probe, but you don't have a proper view of the other structure. What about the contrast? The barium enema could be useful in investigating the degree of stenosis of the bowel, before surgery. That could be an indication for surgery. But also CT virtual colonoscopy is a good technique because it can give you a complete assessment of the colon with a very high accuracy, with a 3D reconstruction of the bowel. This is on the right side. You see the findings at the CT virtual colonoscopy of this woman that you can see in video 16. The ultrasound is in video 16. You can see that this was a very big nodule on ultrasound, a bowel nodule, and we did a virtual colonoscopy, and you could see that the lumen is a high percentage of stenosis. The disadvantage of the virtual colonoscopy is that...
Okay, we have just watched video 16.
Okay. In my thoughts, the disadvantage is that these are very young women. So you may have to irradiate these women with the CT. There are a protocol with low dose that you can use, but still you have to irradiate these women. So that could be a disadvantage. This is another virtual colonoscopy, and you can see that there's a nice reconstruction of the bowel with a stenosis. And you can see the nodule on video 17.
We are now watching video 17. Okay, we have just watched the last video.
Thank you. So in the last months, and this is very recent, we have abandoned the virtual colonoscopy because we started doing MRI. MRI has the advantage of giving you a complete view of the pelvis. So it is more accurate to study the extension of the endometriosis lesion in all the structures of the pelvis. And we've started with the collaboration with our radiology department to have an MRI on all women that are going for in which there is suspicion of deep endometriosis. And we use a rectal gel. So basically we instillate like a bottle of the ultrasound gel that we used to do in ultrasound in the rectum. You don't have to do any other preparation. You can have a microclism the morning of the exam, no more than that. And you can have also, you can do a thin slice MRI and a 3D reconstruction of the bowel lumen. Endometriosis lesion on MRI have that shape of mushroom cap that you have on ultrasound, and you can see all the retraction behind the uterine cervix. So you can reconstruct the signal of the gel into an MRI virtual colonoscopy. So you can see that the lumen is narrowed here on the left. There's a narrowing of the lumen at the level of the endometriosis nodule. So the messages that I would like for you to understand is that you should use ultrasound as the first line imaging technique for to diagnose deep endometriosis and also to follow up these lesions. But we need to standardize the way to perform the examination of the posterior compartment. We need to standardize also the terminology of this lesion that once we used to call altogether like rectovaginal endometriosis. But now we've started to understand that they are affecting different sites and they should name according the sites, the anatomical sites that they are affecting. Transvaginal ultrasound should be a part of a multidisciplinary approach to endometriosis. So gynecologists should work together with sonographers, general surgeon, and radiologists. The deep endometriosis lesions most of the times are multifocal. So if you see a rectal lesion, there's a high chance that this woman has other location involved. The accuracy of transvaginal ultrasound may be limited for higher sigmoid lesion. So if a lesion is above the rectosigmoid junction, you may miss with the transvaginal approach. The sigmoid rectosigmoid junction is, to give you an idea, at the level of the promontorium. Another site which may be difficult to investigate with ultrasound is the right bowel, so lesion of the cecum and the ileum. So this was the investigation of the posterior compartment and the bowel endometriosis. Now I would like to give you some annotations on extrapelvic endometriosis. There are some other sites of interested by endometriosis outside of the pelvis, and the abdominal wall is the most frequent of them. Usually the most frequent abdominal wall lesion is the lesion that you have after surgery. That could be a hysterectomy, a cesarean section, so any procedure that involves the uterus. But there are also other abdominal wall lesions that they are primary. So basically these women, they did not have surgery, but they developed this kind of endometriosis. This abdominal wall lesion, they should enter differential diagnosis with sarcomas, lymphomas, and desmoid tumors. On ultrasound, they have a very similar appearance to what we've already seen at the level of the bowel. So they look like hypoechoic nodules. They usually have irregular margins, and they may have internal vascularity. Also, they may have, as you see on the right side, also cystic areas. And also the clinical picture, it should arise your suspicion of endometriosis, because these nodules, they're usually painful during the menstrual periods, and these women have a history of uterine surgery. There's also a site which is the umbilicus that can be involved by endometriosis, and these are usually bluish nodes that are painful during menstruation. But this is less common than what we've seen before. Thoracic is even less common, and usually the best way to depict this lesion is the CT scan. Also, there is endometriosis of large muscles, such as the adductor compartment, the rectus abdominis muscle, and endometriosis of the gluteus muscle. Endometriosis can also be located in the liver and the gallbladder, but these entities are extremely rare. So we've seen posterior compartment and extrapelvic endometriosis. Should we have a pause? Should we go on with other presentations? Do you have any questions?
Okay, Tommaso, we are now going to make some questions. I'm going to present doctora Patricia Farías, jefe médico del área de ecografía del Centro Médico Teseba. Patricia is going to speak with you and make you... maybe you're, because of that little problem we're having, you're not going to see her, but you're going to listen to her. And she's going to make some questions that people in the audience have made, okay? Ok, Patricia, doctora Patricia, ¿cómo le va? Bienvenida. Y bueno, ahí la está escuchando Tommaso para que le pueda hacer las preguntas.
Hello, Tommaso. How are you? Nice to meet you again. I'm going to ask you some questions. Thank you. Do you use three-dimensional ultrasound to study deep endometriosis? And if you use it, how long is the examination? This examination adds more information for you?
Well, I don't think there's a real advantage on using. Okay, now I can hear, because there's a very strong noise. Sorry.
Okay, Tommaso, we are listening to you. You can answer the question now.
I can speak. Okay. Well, actually, I don't use routinely 3D ultrasound for to see the bowel endometriosis and endometriosis, for example, of the uterosacral ligaments. I'm not using it routinely. I think it's a good tool to start learning how this structure appears on ultrasound. Also because you can free the patient after you've done your sweep, for example, of the lower rectum. You can free the patient, and you can use all the post-processing tools to navigate into the volume and look at the different structures without having the probe, without keeping the probe inserted. So it is, I think, more a tool that you can use to learn than a tool that you can use to improve your diagnostic ability. I think it can add something more for the study of the uterus, and we will see it with the presentation on adenomyosis, rather than with the posterior compartment. Also because the posterior compartment is quite big, and you cannot contain all these structures in a sweep, in a 3D sweep. So you have to always tilt the probe somewhere else and follow this nodule. So I think the 2D dynamic study is more useful to you rather than the 3D ultrasound. It is actually another application. It could be to confront your diagnosis with other gynecologists. For example, if you see a nodule, a bowel nodule, you can have a sweep, you can acquire the volume, you can store the volume, and then you can see it and confront with another, even days later, with another gynecologist which is more expert than you.
Thank you. I have another question. You teach us that patients for this kind of study have to have a different preparation for this. How do you choose the patient, the woman, who is going to have an ultrasound examination with more details? Because you have to prepare this patient.
Yes, I mean, I don't give any kind of preparation to these women before this exam. Some authors suggest to give like an oral laxative the day before, and then the morning of the exam a microclasm to make the bowel more clean. But I usually don't do any kind of preparation. For probably if you are at the beginning of this kind of examination in your learning curve, it could be useful. But then if you have learned how to see this nodule well, probably you don't need any preparation. These women that I see in my ultrasound clinic, they are women that are referred from other gynecologists, for example, because they have an endometrioma, or because they have symptoms suggestive of endometriosis, or they have a previous surgery for endometriosis, for example. So they are very selected women which are at high risk of this pathology. So I do this examination in all women. But if you are suspecting, if you have a suspicion of endometriosis based on tenderness of the pelvis, tenderness points, based on the suspicion of an obliteration of the pouch of Douglas, you should do this examination in these patients. So look carefully at the posterior compartment if you have this kind of signs.
Well, we are going to go on with the last question, and then we can go on with the presentation. How do you think about using transvaginal probe to transrectal examination?
Yes, I normally use the transrectal approach only in cases in which, for example, women that they don't have sexual intercourse, or old women that they have a stenosis of the vagina, and the transvaginal approach is not feasible. But I don't think there's any advantage for these women, these young women with endometriosis, to look from the rectum rather than the transvaginal approach.
Okay, thank you, Dr. Tommaso Bignardi. We can continue now with the presentation.
Okay, so we can put the adenomyosis one.
Okay, now we are loading the other slides. So when you see them on your screen, you can start with your presentation.
So we've seen
Aprovecho para avisarle a los que están conectados
now
que si quieren enviar preguntas lo pueden hacer a través del chat, que nosotros las vamos a ir leyendo acá y en la medida de lo posible le vamos a pasar las preguntas al doctor para que vaya contestando.
we've seen the involvement of the posterior compartment. Now we should focus on the uterus. So what is called the central compartment of the pelvis. Involvement of the uterus by endometriosis is called adenomyosis, which histologically is defined as the presence of endometrial glands in the myometrium. This presence arises inflammation and hyperplasia of the smooth muscle cells. So basically the same thing that happens in the muscularis layer in the bowel. This adenomyosis can be diffuse, so can involve the full thickness of the uterine wall, or can be focal, so only small regions that are usually close to the endometrial myometrial junction. Very rarely there's an involvement of the cervix. The prevalence in the literature is there's a very large span of described prevalences that goes from 5 to 70% of all hysterectomy specimens. The more frequent age is the late fertile age, so from 35 to 45 years of age. And usually adenomyosis can be associated to other uterine pathologies that are dependent from the hormonal stimulation, from the estrogens, like endometrial hyperplasia, myomas, and endometrial carcinomas of the first type. This is a prospective study on the prevalence of adenomyosis that was done in a gynecological clinic that was led by Davor Jurkovic in the UK. Davor basically, because of this inconsistency of described prevalence in the past literature, they decided to have a look at the capability of the ultrasound on the diagnosis of adenomyosis, and they, based on an ultrasound diagnosis, based on criteria that we'll see, they were able to see adenomyosis in 20% of women that were attending a general gynecological clinic. So this is, I think this is the most realistic estimation of the prevalence, 20% of women of this age. Women with adenomyosis commonly present with symptoms like heavy menstrual bleeding, pelvic pain, infertility, dysmenorrhea, and pain during intercourse. What we see on histology is the presence of these endometrial glands inside the layer of the myometrium. And this was one of the first studies that were correlating the ultrasound diagnosis with the diagnosis made up with MRI. And they could see that there was already a good correlation. And this was done almost 10 years ago. So now that our capability of making an ultrasound diagnosis have improved, probably also the prevalence of this pathology will increase. The adenomyosis usually involves the junction of the endometrium and the myometrium layer. This is the most common region, which is very important in fertility, in preservation of fertility, and in the regulation of the menstrual flow, and is the most common site of involvement of these lesions. This is a correlation of what we see on ultrasound to the histology, and in the upper pictures you can see that there's an endometrial lining. Just below that there's a microcyst, so an anechoic cyst that you can see with the calipers on, and they did an hysterectomy, and on the right you could see that microcyst corresponded to a dilated gland, dilated cyst, which was covered by the endometrial lining inside the myometrium. And this is focal adenomyosis. This is what we call focal adenomyosis. Below this picture, you can see another ultrasound picture with an appearance of an heterogeneous myometrium that histologically proved to have multiple endometrial glands inside. That you can see all these arrows. So this was a diffuse involvement of the myometrium. Another appearance of this pathology of adenomyosis could be an adenomyoma. So this aggregate of endometrial gland that are all close to each other, and they form like a myoma, which is not a myoma, but it is an adenomyoma. These glands are covered by a thickening of the connective tissue that separates it from the myometrium. So this is a typical appearance of a adenomyotic uterus, and what strikes you is the first thing is the globular appearance. So it doesn't have the common pear shape, but it resembles more a sphere. And so the globular appearance of the uterus is the first criteria to diagnose adenomyosis. Another criteria is the presence of an heterogeneous myometrial texture. So you can see that the myometrium has a heterogeneous appearance, which is caused by the presence of these endometrial glands that are diffused, scattered all over the myometrial texture. Another criteria for diagnosis is the presence of small cystic spaces within the myometrium. So these glands may become dilated, and you can see this dilation on ultrasound. Usually these small cystic spaces are close to the endomyometrial junction. Another criteria for diagnosis is the fact that the endometrial stripe is irregular and is ill-defined. You cannot see clearly the passage between endometrium and myometrium, and sometimes you are not even able to give an estimation on the endometrial thickness. This is a picture of a diffuse superficial adenomyosis. This means that the adenomyosis is affecting the most superficial layer close to the endometrial layer. You can see these cystic spaces on the left close to the endometrial stripe. You can see that the endometrial stripe is not well defined. And this is a picture of a diffuse deep adenomyosis. So in these cases, this infiltration of endometrial glands goes beyond interesting almost all the thickness of the myometrium, so that all the uterus appear increased in volume and has a globular appearance. If you put Doppler in, you can see that there's a diffuse vascularization. You cannot see a perilesional vascularization, a ring vascularization, as you can see in fibroids lesions. Another typical aspect is the presence of what somebody called the myometrial cracks. So basically there are stripes that goes from the endometrial lining deep into the myometrium, and you can see it on the right side. And this is basically the invasion of the endometrium inside the myometrial wall. And with the right resolution that we have now, you can see these stripes quite clearly. These small cystic spaces that we explained, sometimes they can be quite dilated, so sometimes they could appear like a quite big cyst inside the myometrium, and these are most of the times they are in communication with the uterine cavity, and they become quite dilated, and they are very specific for adenomyosis. Histologically, they correspond to dilated endometrial glands. If you put the power Doppler in, you can see a diffuse vascularization and also an intralesional vascularization. On the lower right corner, you can see that there's an endometrial stripe which is homogeneous, hyperechoic, so it should correspond to a secretory endometrium. On the right, there's a small spot that has a similar echogenicity, that is a focus of adenomyosis in communication with the uterine cavity, and is basically lined by the same endometrium, which is the same echogenicity of the endometrial lining. This is another picture of a focal deep adenomyosis. You cannot see a capsule, a pseudo capsule, as you can see in fibroids, and also you can see the stripes that I told you before, that goes from the endometrial cavity across all the uterine wall. This is another picture of focal adenomyosis. You can see these cystic spaces on the left, anechoic spaces that projects a shadowing. So on the right side, there's a very big adenomyoma. Sometimes they can have this appearance, so they can be confused with a dilated uterine cavity. It's not the first time that they refer patients to me because of hematometra, with a suspect of hematometra, for example, but then turns out to be an adenomyoma, a dilated adenomyoma. This is another picture of a dilated cystic space in focal adenomyosis, which was in communication with the uterine cavity. This is a meta-analysis on the capability of ultrasound to make a diagnosis of adenomyosis, and there are quite different reported sensitivity and specificity, but they are all around, I would say, 80%. In some cases, it goes up to 89%. So we can skip this one. MRI is and transvaginal ultrasound is probably similar based on this meta-analysis. The accuracy of these two techniques is quite similar. On MRI, it shows the adenomyosis shows as a thickening of the endomyometrial junction that you can see on the left. The cutoff for diagnosis is described to be more than 12 millimeters of thickening, and also on ultrasound you are able to study this junction of the endometrium and myometrium with a high accuracy using, for example, harmonic imaging. It improves your ability to see this junction. Sometimes sonisterography can confirm your suspicion of focal adenomyosis, basically enhancing your ability to see the communication between the endometrial cavity and these myometrial cracks, these myometrial cysts. So sometimes if you have any doubt, you can do a sonisterography and you may see a dilation not only of the endometrial cavity but also of these myometrial cysts and cracks that are in communication with it. This was a video that I wasn't able to upload, I'm sorry, but this was a video of a sonisterography. You can see the cavity which was dilated by the fluid, and on the right side there was this cystic space which was lined by a similar endometrium to that of the endometrial cavity, and you could see it slowly dilating during sonisterography. So to confirm that these spaces are in communication with the endometrial cavity. Now we can skip this one. A differential diagnosis, which is of paramount importance to the surgeon that is going to operate these women, is to make a differentiation from myomas to adenomyosis, because adenomyosis can be a real problem for a surgeon if he tries to enucleate it, because you cannot find a cleavage plane. So it may end up doing a lot of dissection inside the myometrium, and then you have to close and resuture it without having resolved anything. Probably you have made these patients bleed a lot, and they don't have any benefit from the surgery. So it is very important to try to distinguish these two entities. And these two criteria can help you. For example, the presence of lacunae inside these lesions. These are typical of adenomyomas, lacunae, myometrial cysts. So if you see small dots, anechoic dots inside these lesions, it is more likely that they are adenomyomas. The other criteria is the presence of myometrial the presence of a clear margin, a clear capsule. You can see a clear capsule in a fibroma, but not in an adenomyoma. Sometimes this diagnosis can be tricky, because myomas may sometimes appear in very funny way. They may have different kind of degeneration, and they can resemble sometimes adenomyomas, and also sometimes things that, for example, on the right, that they are completely calcified. This is another entity which is the atypical polypoid adenomyoma. Sometimes adenomyosis can have a polypoid appearance inside the cavity. And this is called polypoid adenomyoma. This polypoid adenomyoma sometimes can be atypical, and this correlates in 10% of cases with the presence of an endometrial carcinoma. So if you see a submucosal myoma which have characteristics of an adenomyoma, you should carefully investigate the endometrium. So to summarize the differential features on ultrasound between myomas and adenomyosis, the presence of an echo structure with stripes is typical of adenomyosis, while in myomas it could be very variable. Regarding the morphology, in adenomyosis you have ill-defined margins. You are not able to see a capsule, while in myomas you are able to see a usually round ovoid lesion, well-defined lesion. Apoechoic areas are usually not present in myomas unless there's a particular kind of degeneration, but they are quite frequent in adenomyosis. In myomas we have a pseudocapsule, while not in adenomyosis. Usually, if you put the power Doppler, you have a peripheral vascularization in myomas, while a scattered intralesional vascularization in adenomyosis. "3D ultrasound can, in this case, help you a bit to make a diagnosis of adenomyosis, because you can enhance all the features that we've already seen on 2D ultrasound. You can, with some tricks, enhance these features, and also you can get a coronal view of the uterus that is useful to see if you want to study the junction between the endometrium and the myometrium. So the coronal plane can be useful for the diagnosis of adenomyosis, and so as I will try to explain to you, 3D ultrasound can be helpful in the diagnosis of adenomyosis because it can depict in the coronal plane quite well the junction between endometrium and myometrium. In this reconstruction you see a secretory hyperechoic homogeneous endometrium and an hypoechoic stripe at the level of the myometrium just next to the endometrium. This is the endomyometrial junction. And in this case it looks like well-defined and normal. If you use the VCI, so and also a rendering mode, it can even be more clear, this passage, because of the much more contrast between this structure. Because the VCI imaging basically take a slice of volume and make a combination of all the signals inside this slice. So you can see that there's a much more contrastation of this region. I usually use a slice thickness of 2 and 4 millimeters to study this region. I'll go back because this is a multiplanar display of an adenomyotic uterus. You can see that the endometrial stripe is not well defined. There's a thickening of the posterior wall. There's a quite an image of stripes that goes from the endometrium to the deep of the myometrium. If we put the VCI on, you can see that these features are even more clearer. You can see much more clear the myometrial cyst, anechoic cyst, the stripes, and the appearance of an heterogeneous myometrium. This is an image without VCI. If we apply VCI, you can see these features much more clearly. Also on the coronal plane, you can see the interruption of this endomyometrial junction. On the left, you can see quite a nice picture of a infiltration of the endometrial layer inside the myometrium with an interruption of this endomyometrial junction zone. This is a nice paper that I suggest to you for reading that was made by Caterina Exacustos in Rome, and it gives you quite a nice overview of all the diagnostic criteria that we use for the diagnosis, for the ultrasound diagnosis of adenomyosis. These are nice coronal planes that shows a normal, on the left, a normal endomyometrial junction, and an interruption of this hypoechoic layer by adenomyosis implants on the right side that you see in the right picture at the level of the white arrows. A very specific diagnostic criteria, as I've already explained to you, is the presence of myometrial cyst that can be quite well contrasted by the VCI. You see that on the coronal plane, the junction between endometrium and myometrium, which is normally has a nice hypoechoic appearance, in this case is not well defined. This is a summary of the ultrasound criteria with the likelihood ratio of each of them, and we see that the myometrial cyst has the highest likelihood ratio for the diagnosis, so it's the best criteria that performs with about 24.3 positive likelihood ratio. So it increases the presence of this cyst, the risk of adenomyosis 24.3 times. Another criteria is the presence of an asymmetrical myometrium with usually a more thickened posterior wall. Another criteria is the hyperechoic striations and the heterogeneous myometrium. And I would like also to give you some advice about treatment, because we do the ultrasound diagnosis of adenomyosis, and then we are also in charge to follow up this patient to give some advice to them. And I had a very good feedback with Mirena coil, because it can give a local distribution of the progestogen, and is very active in reducing the heavy bleeding and the dysmenorrhea in these women. When you follow up these women with the Mirena coil in place, you can see after a few months a very clear change in the ultrasound appearance of adenomyosis. This is the baseline scan when we inserted the Mirena coil in this patient, and you could see that the uterus has a globular appearance. You can see small myometrial cysts, a diffuse vascularity, no capsule. So the diagnosis of adenomyosis was made, the Mirena put inside, and we scanned the woman. This is a coronal image showing the Mirena. We scanned the woman. This is another picture of the baseline scan. This is after a year. You could see that the globular appearance of the uterus is less strong. The uterus is smaller, and the myometrium is more homogeneous. And this is the picture after 2 years of Mirena, with a very clear reduction in vascularity inside the myometrium. Okay, I think I have done with these 2 presentations. If you have questions about adenomyosis,
Okay, Tommaso, thank you very much. We have watched your interesting presentation. As I have just told you, because of matter of time, we have to stop here today. But anyway, Vanina, we're going to get in touch with you in order to tell you how we're going to make with the other presentation, how we're going to finalize this in another day, okay? I want to thank you very much. Y también agradecerle a todas las personas que estuvieron conectadas, que estuvieron viendo la charla, por la atención. So, Tommaso, if you have some last words before we get offline, we would like to hear you.
Okay, no, I just wanted to say hello to everybody there, to Patricia, Diego, Vanina, and we'll keep in touch to make the other 2 presentation happen. Now it's time for me to go to work. Ciao.
Ok, Tommaso, thank you very much. Chao. Y a todos, muchas gracias por haber estado conectados. Les agradecemos y nos vemos en un próximo encuentro online. Muchas gracias.